Hello people, this is Dr Muskan this side and I'm going to discuss one case with you. It's very beautiful case. Here is 49-year-old male who has came on OPD basis with complaints of chest pain and cough since 3 days, abdominal fullness since 3 days, loose stools since yesterday. The patient, HOPI, the patient was apparently alright 3 days back when he developed chest pain on left side which was sudden on onset, non-radiating, associated with cough, which was productive with expectoration, white in color. Patient also complained of loose stools which were multiple, watery, yellowish in color, not mixed with any blood and mucus, negative history of vomiting, past history. There were no comorbidities like type 2 diabetes mellitus, hypertension, epilepsy, coronary artery disease, thyroid or any other comorbidities. Past medical history, he is consuming medications for liver disease and he is known case of CLD since 4 years. Past surgical history is non-significant. Personal history, he is chronic alcoholic since 32 years but he is not consuming alcohol from last 1 year, but he drinks occasionally in this passage of 1 year. He is chronic smoker since 20 years but he quit smoking in the past 1 year and there is no history of tobacco use. On examination, decubitus, the patient is conscious, oriented to time, place and person. He is cooperative, there is no anxiety or confusion. He is maintaining 100% SpO2 on 50% FiO2, P plus 6 and he is on NIV mode. Vitals seems to be normal within the normal limits. Parallel was moderate, that suggests us of anemia. Icterus was mild, that suggests us of jaundice. Edema, lymphadenopathy, cyanosis, clubbing were absent. Systemic examination, CNS examination, GCS was 15 by 15, E4, V5, M6 and bilateral pupil reactive was present. CVS examination, S1, S2 was present. Respiratory examination, there was decreased bilateral air entry and there was bilateral V's present, more on left side compared to right. On per abdomen examination, the findings were hepatomegaly, splenomegaly, it was soft, tenderness was present and it was diffuse in nature. Investigation picture of the patient shows that patient is anemic. There was hyponatremia, hypoalbuminemia, there was decreased urea, decreased creatinine, increase in alkaline phosphatase level. Other was tropical fever tests such as dengue DO, NS1 antigen, IgG, IgM, malaria test, typhoid IgG, IgM, all were negative. On peripheral blood picture, there was normocytic normochromic anemia present. Procalcitonin was normal, it was 0.19 nanogram per dl and we have ruled out sepsis with the help of procalcitonin reports. Iron profile test was done in which iron was reduced, TIBC was reduced, transferrin was reduced and ferritin was normal, suggesting us of anemia only. Reticulocyte count is very important in the patient of normocytic normochromic anemia, but in this patient it is normal, 0.5% it is, and normal range of reticulocyte count lies in 0.5 to 2.5, and when reticulocyte count is normal, it suggests of some conditions such as anemia of chronic disease, renal failure, early folate deficiency, early vitamin B12 deficiency and effect of drugs. On ultrasound, there was impression of mild hepatosplenomegaly, bilateral mild to moderate pleural effusion, mild to moderate ascites. Chest X-ray findings, there was PA view, chest X-ray, soft tissue, bony cage intact, exposure was normal, there was expiration film, anterior ribs were visible more than 8, both CP angles were blunted, more on right side compared to left, suggestive of pleural effusion. There was homogeneous opacity in the lower zone of the lung on the right side, suggestive of pneumonia. ABG shows us the finding of respiratory alkalosis, electrolytes were reduced, there was hyponatremia, hypokalemia, hypochloremia and hypocalcemia. Urine output was very less, there was yellow color urine and yellow color stools. Flapping tremors or liver flap was present. So the differential diagnosis is acute gastroenteritis because there is reduced electrolytes, loose motions, abdominal pain and tenderness, And liver disease, CLD, of course, is a known case, and the positive findings were icterus, splenomegaly, ascites, pleural effusion, flapping tremors, normocytic, normochromic anemia. Just 1 minute. Yeah. So what all other findings we see in the patient of CLD? That is leukonychia, white color nails, spironavy, palmar edema, ankle edema, gynecomastia, portal hypertension, esophageal vessels. And how we see portal hypertension present hai ki nahi hai? We see the levels of platelets which are reduced, thrombocytopenia, splenomegaly, and esophageal vessels. Other is fetor hepaticus, that means breath smells like fleshy open corpse. Flatal varices, that is hemorrhoids, and he also has past history of hemorrhoids which are corrected now. Dilated abdominal veins, that is caput medusae, melena, hematemesis, and that's all. जो पॉजिटिव फाइंडिंग्स थी CLD के पेशेंट में वो मुझे ज़्यादा नहीं मिले इस केस में, बिकॉज उसने शराब और स्मोकिंग करना छोड़ दिया था पिछले 1 साल से, एंड ही वाज ऑन रेगुलर मेडिकेशन. अदरवाइज जितने मैंने CLD के केसेस पहले देखे हैं ऑलमोस्ट मैंने मोर्टैलिटी तक जाते हुए देखे हैं, एंड पूरे पेकुलर फीचर्स देखे हैं जो पेशेंट में प्रेजेंट होते हैं. बट इस पेशेंट में देर इज़ रिकवरी एंड देर इज़ अ लेस सिम्टम्स. सो yeah, it was a good case. I really enjoyed working on this case, and I hope you also come to know some good points such as normocytic, normochromic anemia में हमें रेटिकुलोसाइट काउंट देखना होता है, बहुत important होता है. And I also acknowledge you with all the 15-16 points which we see in CLD patient. That's all. Dr. Muskan is signing off now.